We try again. Okay, that's fine. Good morning to everybody, and thank you again to Professor Maletti and Professor Lugli for this kind invitation. And it's a great pleasure to introduce the director of the course, Marzia Lugli, with the first presentation, Patient Selection and Interventional Technique for Managing DVT.
So this will be just a quick overview on the techniques that we have today in our hand about early thrombus removal, given that after me all the speakers will go perfectly through into all these important issues. Everything starts from the acute DVT, and when it happens, what to do? Should we go conservative or should we go through an operative treatment? We know that since more than 10 years ago in United States, we really have already given important indication that at the end did not changes. Iliofemoral DVT, less than 2 weeks, there were a 2C indication, while with the venous ischemia there was 1A. And we are talking about more than 10 years ago. Then in that period we have only catheter thrombolysis, more or less, and sometimes I would say mechanical homemade thrombolysis system. That's what we use when we have nothing at that period. Then comes all the mechanical devices. Today companies are helping us a lot in this direction, providing different approach, different way to work with or without a pharmacological assistance, with ultrasound, with aspiration. So in fact, today we can work in a very wide way in this type of problem. And what about recommendation? There has been a strong variation. We went from 2C, from 2AA in 10 years. The population still remained the same. Iliofemoral DVT, young patients, good expectancy of life. And what is important to know, if we analyze data from the literature that I think that Makis after will tell us much more better than me, PTS occurrence after thrombolysis shows that the data are in favor of ATR, despite some important large studies such as the ATTRACT that really, we can say, bring back the watch for many years. And also the bleeding risk seems to be in favor of ATR because it's very low, the rate of complication. So nevertheless, it come out an important element. Should we limit us to 50 days? That's what we have in our mind. That's what is indicated into the guideline. This is a typical 50-day occlusion with a very large femoral vein, but today we are moving towards different situations, 35 days, sometimes much more. So we are pushing over the guidelines every day much more. Despite all of this, a minimal number, less than 1%, 0.1%, maybe more, less, but I'm a bit shy to say a smaller number than this, go to a correct approach. Some years ago, we make a study analyzing all over the countries, which is the application of the guidelines. It seems to be really very poor. So what are the existence barriers between the application of the techniques that we have in our hand today? In my opinion, there are 4 elements. A difficulty in understanding the disease progression. Today, probably is the most important scientific element. Poor evidence, I think, is much more claimed than real, because today we have a good evidence about ATR application. Availability of centers that are able to perform correctly early thrombus removal, and a lack of education. Generally speaking, an important lack of education. But I say one of the most important elements is that we don't know which one of those patients affected by DVT will evolve towards this situation. We have some data, but that's really something we have to evaluate and we have to investigate during the next year. there are important critical issues. ATR should be treated, who should be treated or should not. I think that today we will learn a lot about this. Which technique, in which case? Recurrent thrombosis on a patient that already has a chronic obstruction. Should we treat or not? And stenting after early thrombus removal. Ever, never, often, which are the numbers that we should apply in this situation? I would conclude saying that despite the severity of PTS that may occur, the clinical picture of those patients, especially young, may strongly affect the quality of life, especially in those young patients. So our task, our task is the reason why we are here today, is to define the correct, the appropriate ratio between risk and benefits and outcomes that we are expecting, helping the patient towards a good choice. Guidelines are supporting us strongly. Industry is working quite hard in this domain. Outcomes are positive, so we are really committed to improve the patient's life in the next future. Thank you.
Thank you, Marzia. We're going to have a lot of discussion at the end, and we're going to move on to our next